Good morning, respected MBBS chairperson and founder of Mahatma Gandhi University of Medical Sciences and Technology, Dr. N.A. Swarnkar sir, chairperson cum Chancellor Dr. Vikas Chandra Swarnkar, Vice Chancellor Dr. Ajay Gulati, Pro Vice Chancellor Dr. V.K. Kapoor, Principal of Mahatma Gandhi Medical College and Hospital Dr. N.D. Soni, senior faculty members, colleagues and students. I welcome you all to the 21st undergraduate combined round of Mahatma Gandhi Medical College and Hospital. Today, the topic of UGCR is Mumps. The chairpersons for today's session are Dr. Rupesh Masan, Professor and Head Department of Pediatrics, Dr. Shweta Mangal, Professor, Department of Community Medicine, Dr. Rajendra Dabaya, Associate Professor, Department of ENT, Mahatma Gandhi Medical College and Hospital. As we commence this session, I invite Dr. Rupesh Masan, Professor and Head, Department of Pediatrics, for his expert view on mumps.
Honorable Chairman Emeritus Dr. M.L. Swarnkar sir, respected Pro Vice Chancellor Dr. Kapoor sir, Medical Director and Superintendent Dr. Jaiswal sir, Convener UGCR Dr. Ojha sir, all faculty members and dear students. On the eve of 21st UGCR on Mumps, today 26 December 2025, I at the outset extend my gratitude to Professor Dr. Ojha sir for extending me the privilege to chair this important session along with Dr. Shweta Mangal, Professor Community Medicine, and Dr. Dabaria, Department of ENT. I was left wondering when I was asked to present the introductory speech of this session, because all of you, the speakers, have worked all through the month to present their presentations on various aspects, starting from anatomy of carotid gland up to the complications and prognosis of mumps. So I compliment all of the speakers along with those who have prepared along with all the students on this occasion. So I thought it's better to present the historical perspective of this disease. How knowledge of mankind has evolved over the ages, that too is as interesting as the disease itself. So it all started, say, about 2,500 years back, when mumps was first described in the Chinese medical literature. Subsequently, Hippocrates, who is also known as the father of modern medicine, is documented the clinical manifestations of mumps in its very simple language quite vividly, when he observed an epidemic in the Greek island of Thessos, way back in 400 BC. Then the word mumps was coined in the year 1600, when it was originally derived from the word mump, which means grimace. That means that the word grimace means the facial expression that we form when someone is in pain while talking or while swallowing. So the word mump is basically a plural form. So the mumps actually is derived from that word. And it was likely called mumps because of the swelling which was caused by the parotitis and which reflected on the facial expressions of the patient. But it was in the late 18th century when Robert Hamilton, he first scientifically described the disease. In 1934, the etiology of the disease, the mumps virus, was discovered by Claude Johnson and Ernest Goodpasture. It is the same Goodpasture of which we know about the Goodpasture syndrome, that is a type of nephritis. So basically, the combination of a physician and pathologist, they discovered mumps virus, and then subsequently in 1948, an inactivated vaccine was developed after having cultured the virus for the first time in 1945. But it was Maurice Hillman who first developed the live attenuated vaccine known as the Mumps vax way back in 1967. That too is quite interesting because he had isolated that virus strain from the saliva of his own daughter, whose name was Geraldine. And from then on, the strain that was developed for the vaccine is known as the Geraldine strain, and that is used in US till now. In 1971, it was Hillman again who combined the mumps virus with measles and rubella to form MMR. And from then on, the entire world started using MMR as a vaccine. But this vaccine, just like any other vaccine, was not without its share of controversies. In 1993, there was an outbreak of meningoencephalitis, that too in Japan, and the scientific researchers, they thought that it might be because of MMR vaccination, following which they clamped down the usage of MMR. However, after a year or two, there was an epidemic of mumps, and then the mumps MMR vaccine was again started being used in the national immunization schedule of Japan. In 2004, MMR was linked with autism. That is, it is a problem in which there is a decreased communicability which is observed in, say, 2 or 3-year-old children. Subsequently, in 2009, that claim was also rubbished. Why? Because the scientific community came to know that this was something related to some kind of study which was not holding that much ground. So, MMR was absolved of all the issues. However, in India, we still continue to have regular outbreaks almost every 1 to 2 years in different parts of our country, mainly because the MMR is not in the schedule. We have MR vaccine only, which is provided at 9 months and at 15 months of age. We don't have the mumps component in that. Despite the position paper on mumps by IAP, that is Indian Academy of Pediatrics, 10 years back, and regular representations to the government by the office bearers of IAP, mumps vaccine still needs to find its place in the national immunization schedule. We as pediatricians sincerely hope that mumps vaccine is incorporated as MMR in the national immunization schedule as early as possible to reduce the scourge of the disease and its complications. Thank you very much, and I now invite the first speaker of the day, Mr. Laksh Kriplani, to present his deliberation on anatomy of carotid gland on behalf of the Department of Anatomy.
Good morning everyone, all the dignitaries, respected faculty members, seniors and my dear batchmates. I am Laksh Kriplani from MBBS Batch 2025 along with my teammates Nidhi Agarwal, Manoj Raj Saini, Sanani Suvalka and Shgupta have prepared a presentation on the topic anatomy of parotid gland. We have prepared this presentation under the guidance of Dr. Pankaj Kumar Singh Sir, Professor and Head of Department Anatomy, and under the moderation of Dr. Abhilasha Marshri Ma'am, Associate Professor, Department of Anatomy. I hope you find this presentation informative. Mumps primarily affect the salivary glands, which are sublingual gland, submandibular, and mainly the parotid gland. Well, what is mumps? Mumps is a highly contagious, non-suppurative viral infection that primarily targets the glandular tissues. It is caused by paramyxovirus, which belongs to genus Rubella virus and family Paramyxoviridae. Its classical presentation is characterized by the painful swelling of the parotid gland, and it creates a distinct chipmunk cheek appearance. Its incubation period lies from 12 to 25 days. It can commonly occur in children of age group 2 to 12. However, it can also occur in adults. Well, how does mumps spread? From an infected person to a healthy person. When the respiratory trough of an infected person enters the upper respiratory tract of a healthy person, it replicates and it goes to the bloodstream, then from bloodstream to the tendons duct and the parotid gland, and cause painful swelling of the salivary gland, mainly the parotid gland. Understanding the detailed anatomy of parotid gland is essential for grasping the clinical manifestation of the mumps infection. So now let's have a quick overview on the anatomy of parotid gland. Parotid gland is the largest and major salivary gland, which has primarily serous fluid. It weighs 25 grams, has an inverted pyramid shape. It has a base, apex, 3 surfaces and 3 distinct borders, which are anterior, medial and the posterior border. It extends from external aquatic meatus to angle of mandible. It is present below, in front and behind the earlobes. It is covered by or enclosed by a dense facial capsule. As you can see in the following diagram, it is a parotid gland is an inverted pyramid shape which is located in a hollow cavity retromandibular space which is boundedly anterior by the ramus mandible, posteriorly by the sternocleidomastoid mastoid muscle and the mastoid process, medially by the styloid apparatus and superiorly by the external auditory meatus. Here we can see the facial nerve piercing the posterior medial surface of the gland and dividing the gland into two lobes, the deep lobe and the superficial lobe. Here the facial nerve relation is important because it is in direct contact with the gland, and during a severe inflammation, its terminal branches can be compressed, which can affect the supply of the facial muscles, which can cause the facial palsy or the Bell's palsy. Coming to the capsular part, the inner capsule is formed by the true capsule, which is formed by the condensation of connective tissues. The outer capsule is the false capsule, which is formed by the investing layer of deep cervical fascia, which divided the apex of the parotid gland into superficial and a deep layer. Due to this unyielding nature of the capsule, growing inflammation can cause severe pain during the mumps infection. Relations are important part of our lives, so they are important here as well. The superficial or the lateral surface is covered by the superficial fascia, skin, and it has also a very important relation with the great auricular nerve. Superiorly, it has relation with the temporomandibular joint and the auriculotemporal nerve. The parotid gland sits in the parotid gland, which is formed by its anteromedial and the posterior-medial relations, which are the mastoid process, which is sandwiched between the two muscles which are posterior belly of digastric and the sternomastoid muscles. It also shares relations with the styloid apparatus and the cavity sheet and its content. Anteromedially, it has relation with the ramisomandible, which is again sandwiched between the two muscles, which are mastoid muscle and the medial pterygoid muscle. Coming to the parotid or the Stenson duct, it opens into the vestibula of the mouth on a small papilla opposite to the second upper molar tooth. It pierces the 4 B's. What are the 4 B's? The 4 B's are buccal pad of fat, buccopharyngeal fascia, buccinator muscle, and the buccomucous membrane. If the parotid gland has a process called accessory process, it may block the duct during the severe inflammation. Coming to the inner region of the parotid gland, which is by the auriculotemporal nerve, it is divided into 3 fibers: the parasympathetic fibers, sympathetic fibers, and the sensory fibers. The parasympathetic fibers is responsible for salivation or the secretomotor function. So it is important to know its pathway. So its pathway begins from the inferior salivary nucleus, which goes down as the glossopharyngeal nerve through the jugular foramen, and it gives a tympanic branch in the middle ear, which forms a tympanic plexus, which gives another branch of the lesser petrosal nerve, which goes down at the optic ganglion. From there, the posterior ganglion or the parasympathetic fibers goes down into the parotid gland alongside auriculotemporal nerve. As we talked about the salivation, now let's talk about why consumption of sour, acidic food triggers sharp pain in the mumps patient. When we intake sour or acidic food, it stimulates strong salivation from the parotid gland. The already inflamed or the swollen parotid gland, it gets irritated and it creates a certain pressure on the blocked duct, which gives rise to the intense sharp pain. Well, alongside parotid gland, mumps also gives complication on other anatomical sites such as inner ear, testes, ovaries, pancreas, brain, and the liver, which we will discuss more briefly in later sessions. Now, I would like to call Prisha Tiwari from the Physiology department to continue this presentation. Thank you.
A very good morning. We, the student of batch 2025, are presenting the topic Physiology of Salivary Secretion on the behalf of Department of Physiology. This presentation is prepared by Naman Shah, Namit Sharma, Nishita Saxena, Riti Bansal, and I, Prisha Tiwari, under the guidance of Dr. Aparna Garg ma'am, Professor and Head of Department of Physiology, under the moderatorship of Dr. Sabir Hussain sir, Professor, Department of Physiology. Here are the learning objectives, which includes the physiological anatomy of salivary glands, composition of saliva, mechanism of salivary secretions, regulation of salivary secretions, functions of saliva, and its applied physiology. Salivary glands. We have the major salivary glands and minor salivary glands. Major salivary glands includes the parotid gland, which is largest among all the three, submandibular gland, whose secretion is maximum among all the three, and sublingual gland. Also, we have minor salivary gland, which is various in number and present in oral mucosa, and they are buccal, labial, and glossopalatine glands. Now, on the basis of nature of secretions, it can be serous, mucus, or mixed, which is seromucus type. Parotid gland is the example of serous type, that means their secretion is mainly watery secretion, whereas submandibular gland is of seromucus type and sublingual gland is of mucus type. Now, what is the composition of saliva? Saliva composed of 99.5% of water and 0.5% of other solutes. Solutes further can be inorganic and organic. Sodium, chloride, potassium, bicarbonate, calcium, phosphate, and thiocyanate are the inorganic component, whereas organic component mainly composed of enzymes, tyline, lipase, lysozyme, peroxidase, histidines, stearine, calcarine, and lactoferrin. Other organic components like mucin, proline-rich proteins, and immunoglobulin A. Daily volume of saliva secretion is 1 to 1.5 liter, whose pH is 6 to 7 and osmolarity is 20 to 150 milliosmol per liter. Mechanism of salivary secretion. The salivary secretion occur in two well-defined stages, and both are under the neural regulation, and they are the acinar secretion and the ductal modification. Acinar cell produce the primary secretion, which is later modified by the ductal cell, where sodium and chloride is reabsorbed and secretion of bicarbonate and potassium takes place. Salivary gland secretion is affected by sympathetic parasympathetic pathway along with neuropeptide substance P. Parasympathetic stimulation will activate acetylcholine M3 receptor to activate protein kinase C, releasing diacylglycerol and inositol phosphate, which stimulate the rise calcium level and mediates the increased volume of saliva. In sympathetic stimulation, norepinephrine affecting the alpha and beta receptor that activate cyclic EMP and protein kinase A and transient saliva volume flow. The neuropeptide substance P promotes salivary secretion by binding to neurokinin 1 receptor that similarly increase the intracellular calcium level and thereby increase the salivary output. The secretion of acinar cell is isotonic to plasma, which goes to ductal cells where sodium is reabsorbed and secretion of bicarbonate and potassium take place, and the ductal cells are relatively impermeable to the water. Therefore, the final secretion is hypotonic. Flow of saliva. The normal salivary flow rate is 0.3 to 0.5 ml per minute, which can be increased to 4 to 6 times when it is stimulated. The following graph shows the concentration of electrolyte with the rate of flow of saliva. As the flow of saliva increases, the sodium, chloride, and bicarbonate increases, whereas potassium decreases as there is a less time available for the secretion and reabsorption of the ions. Phases of salivary secretion. It has cephalic phase, buccal phase, esophageal phase, and gastric or the intestinal phase. In cephalic phase, secretion of saliva caused by the sight or smell of food, which is conditioned reflex. In buccal phase, secretion of saliva due to presence of food in the mouth, stimulating the buccal receptor, which is unconditioned reflex. In esophageal phase, slight stimulation of salivary gland by passing food through esophagus. In gastric and intestinal phase, secretion of saliva due to irritant food in the stomach or the upper intestine happens in the case like before vomiting. Regulation of salivary secretion. The salivary nuclei present in the medulla act as the main control center for salivary secretion. These nuclei receive impulse from the higher center of brain. Stimuli such as smell, taste, sound, and sight of food activate the higher center, and it further sends signal to the salivary nuclei of the medulla. Now, the parasympathetic fibers that passes through optic ganglion release acetylcholine to stimulate parotid gland, and parasympathetic fibers passes through submandibular ganglion releases acetylcholine to stimulate submandibular gland. These stimulation increase salivary secretion via effect on acinar secretion and vasodilation. Also, there are certain conditions which inhibit the salivary nuclei, and they are sleep, fatigue, and the fear. Functions of saliva. Why it is important? Because saliva plays many vital functions such as digestion of starch by the enzyme tyline, and digestion of lipid by the enzyme lingual lipase. Saliva helps in the taste, speech. Also, it performs the buffering action as it contains the bicarbonate ion which neutralizes the acid, maintains the oral pH. Saliva protects the teeth, repairs the tissue, performs the cleansing action. Also, it performs the excretory function as it removes the metabolic waste, drugs, and heavy metals. Another important function is antimicrobial action as it contains the lysozyme, immunoglobulin A, lactoferrin, which inhibits the microbial growth. Saliva helps in the lubrication, mastication, and swallowing of food. We have understood the normal physiology of salivary secretion, but what if its balance disturbed? Then it leads to some clinical conditions like xerostomia, decrease the secretion of saliva, dry mouth predisposes to the oral infections, siluria, persistent increase in salivary secretion common in children, silolithiasis, stone is found in the duct of salivary gland, most commonly submandibular gland, organic particles calcify to form the stones and disrupt the flow of saliva. Infections. Salivary glands are prone to infections due to their constant exposure to the oral cavity. Among the salivary gland, the parotid gland is most commonly affected and most common viral infection is mumps. Mumps virus gains the entry through respiratory tract. Local replication occurs at the site of entry. The virus disseminates via bloodstream, which is viremia, to many target organs, salivary gland being one of their target organs. Acinar cells undergo necrosis, while ductal interstitial cells undergo edema. It may probably disturb the signaling pathway of M3, alpha and beta receptor, which is still under the research stages. Here are the references. Now, I would like to call the Tarushi Sharma from Department of Pathology.
Good morning to our esteemed dignitaries, honorable chairpersons, faculty members, and my fellow colleagues. I am Tarushi Sharma, and I will be presenting on the topic of pathogenesis of mumps. This presentation is prepared by Nakshtra Pawar, Moni Singhal, Parangat Agarwal, Per Sabla, under the guidance of Dr. Manju Raghava, Professor and Head, Department of Pathology, and under the moderatorship of Dr. Anamika Chaudhary, Assistant Professor, Department of Pathology. These are the learning objectives which we will be covering in the upcoming slides. To understand the mode of transmission of mumps virus, explain the pathogenesis and viremia, describe organ-specific pathology, and to outline the immune response and the complications. Mumps is an acute viral infection which causes swelling in either one or both of the salivary glands, although it also infects many other organs. It is caused by the paramyxovirus, which belongs to the family of Paramyxoviridae. Humans are the only known reservoirs for this virus. So, a healthy individual acquires the infection by inhalation of droplets, saliva, or direct contact with an infected person. The virus enters the body and the primary replication takes place in the nasopharynx or the nasal mucosa and the regional lymph nodes. The virus now enters the blood. The presence of virus in the blood is known as viremia, which occurs 12 to 25 days after the exposure. During the viremia, the virus infects multiple tissues and organs, causing mumps. Both humoral and cell-mediated immunity are involved in the immune response of the mumps. IgG and IgM antibodies are formed, along with which T memory cells are also formed, which are crucial for long-term defense and preventing severe diseases. Pathogenesis or systemic complications. As we have just talked about, that during the viremia, the virus infects multiple tissues and organs. These are the sites: parotid gland, testes, ovaries, eyes, inner ear, central nervous system, peripheral nerves, and the pancreas. Mumps in the parotid gland is usually associated with parotitis. Mumps parotitis is bilateral in 70% of the cases. The gland appears enlarged, has a doughy consistency, the external surface appears glistening and reddish brown on cross-section. On microscopic examination, we find lymphocytic infiltration along with macrophages and plasma cells. Interstitial edema is also found. Neutrophils and necrotic debris may fill the duct lumen and cause focal damage to the lining epithelium. To understand it better, we'll be referring to the histological slides. This is a normal histological slide of a parotid gland. Here you can see the normal ducts, the serous acini, and we have myoepithelial cells which surround the serous acini. Now to compare it, we'll be referring to the histopathological slides of the mumps virus. Here, we can see there is lymphocytic infiltration along with macrophages and plasma cells. We can see edema, the interstitial edema, and ductal epithelial damage is also present but not well appreciated in this diagram. Mumps in testes and epididymis is associated with otitis. The tunica albuginea tightly contains the testes such that it compromises the blood supply, leading to infarction. The testicular damage can also lead to scarring and atrophy, and in severe cases, it can cause sterility. Mumps in central nervous system is associated with encephalitis and meningitis. The virus enters either via the choroid plexus in the CSF or via the retrograde penetration from the cervical lymph. Mumps encephalitis causes perivenous demyelination, which is a type of nerve damage where the myelin sheet around the blood vessels in the brain and the spinal cord gets inflamed and destroyed. And perivascular mononuclear coupling, wherein the immune cells that are the macrophages and the lymphocytes cluster around the blood vessels in the brain and the spinal cord. Mumps in other organs, which includes the inner ear. The virus infects or damages the organ of Murti and cochlea, which can cause transient to permanent hearing loss. In the ovaries, unilateral oophoritis is also seen. In pancreas, the virus infects and damages the acina cell, which causes release of the digestive enzyme, causing parenchymal and fat necrosis. Neutrophilic-rich infiltration is also seen. In the eye, it causes conjunctivitis, which is the inflammation of the eye's clear membrane conjunctiva. Lacrimal mumps, which also refers to capsuloadenitis, which is the inflammation of the lacrimal gland. Keratitis, which is the inflammation of the cornea. Optic neuritis, which is the inflammation of the optic nerve. Retinitis, which is the inflammation of the retina. It can also lead to blurred vision and also cause permanent vision loss. Thank you. Now I would like to call Tarushi from the Department of Microbiology to continue this presentation further.
Good morning, everyone, respected dignitaries, esteemed faculty members, seniors and dear colleagues. I am Ayushi Joshi, and I, along with my team members, Bhumika Kularia, Himatri Gautam, Pooja Chaudhary and Sejal Tilania, are here to talk about the etiology, transmission and diagnostic test of mumps under the guidance of Dr. Ved Prakash Mamoria sir, our HOD in the Department of Microbiology, and under the moderatorship of Dr. Snigdha Purohit ma'am, our assistant professor in the Department of Microbiology. To begin with, mumps is an acute viral infectious disease which has been classified as bio-level safety 2 agent and is a risk group 2 human pathogen. Now it is pretty common in children as well as young adults, and it is spread by the respiratory droplet infection. Now let us talk in detail about the etiology and the structure of this mumps virus. So it comes from the family of Paramyxoviridae, from the subfamily Orthoparamyxoviridae, and belongs to the genus Rubeolavirus. Now talking about its structure, it is a negative sense enveloped single-stranded virus, and it consists of its own RNA-dependent RNA polymerase, which is also called the L protein. You can see in the diagram as well. This is the polymerase, that is the L protein. So this entirety of the virus, it has a lipid bilayer which has been derived from the host cell membrane. This part. Now in between them, there are surface glycoproteins which are embedded in these lipid bilayer membrane. Two important being the HL protein and the F protein. Now the HL1, which is the hemagglutinin neuraminidase, it provides the attachment to the host cell membrane. Second, which is the F protein, which is the fusion protein, it is actually involved in the syncytium formation. We also see that there is presence of this matrix protein. This is the matrix protein, brown one. This is actually stabilizing the structure of the virus. Now we also see that it has SH gene which is highly variable. It can be either in between the F protein or the HN protein. Now the mumps virus, it consists of only single serotype, but it can have multiple genotypes, that is 12 from A to N. The one which is more common in India is the genotype C. Talking about its transmission, the source is infected human. It can either be saliva or respiratory secretion, also urine, but only up to 14 days. We also see that subclinical cases or individuals who have been recently vaccinated can also be responsible for the shedding of the virus. The mode of contact is direct contact. It can also be the airborne infections. Fomites as well as close contact outbreaks are also pretty common. We see that the incubation period is about 16 to 20 days on an average. That it requires 16 to 20 days for the virus to stay in a person's body. Then it starts showing the symptoms. Infectivity being 7 to 9 days after the onset of parotitis. Now the specimens for diagnosis. So we need to collect sample in order to diagnose something. So there are two types of samples. We have the primary sample and we have the secondary sample. Primary or the preferred sample are the buccal or the oral swab, which are collected with the help of flock swab. This is the flock swab. We also have the secondary samples like CSF as well as urine samples, but they are only collected in severe and complicated cases like encephalitis or meningitis. We also have a special transport technique called the VTM, which is the viral transport medium. So it is a special liquid medium which is used to transport these collected samples. Now timing is very crucial for collecting these samples. It has to take place within 3 days after the onset of parotitis, because at that particular point of time when we are putting the RT-PCR, the viral load will be the highest. We also see that not only it enhances the process of RT-PCR, but also the viral isolation sensitivity is also enhanced. Now for any kind of diagnosis that we are doing, successful detection heavily relies on two things: the timing of our collection and the quality of the clinical sample that we are collecting. Now, when talking about mumps, there are three main diagnostic tests which we can do. First is the RT-PCR one, which is the molecular testing. Herein we are detecting the genome, that is the viral RNA. Second being the serological method, where we are detecting the host antibodies. Third being the viral isolation test, where we are detecting the live mumps virus. Firstly, we have the molecular method of diagnosis. Now, this is the RT-PCR method, which is preferred for detecting the viral genome over the serological method, not only because it helps in the early detection, but also it is highly specific and sensitive. Here also we see that this is preferred test for not only outbreak confirmation, but also for genotyping. Again, the preferred sample becomes the throat or the buccal swab. Other samples include the serum, CSF, as well as urine samples. Now, the second method is the serological method. So, in the serological method, we are aware that the IgM appears within the days of the symptom onset, but it has to be detected with the help of IgM captured ELISA, which is the most sensitive serological method. So, we have this graph and we have drawn this table with respect to this graph. So, here in the second part, we can see that in the table we have the early acute phase. In early acute phase, the IgM is positive, and this is the best time for IgM captured ELISA. In cases of recent infections, we see that both the IgG and the IgM both are positive. That's why they are overlapping. We can see here as well that this is overlapping. Sorry. This is overlapping. That's why at that particular point of time, ELISA might not be very useful. And if the if a person has IgG positive antibodies, it is indicative of two things. Either he has developed immunity for the mumps virus or has gotten the mumps virus in the past itself. One thing which is very imperative when one is talking about the serological test is, even though a person might have positive IgG or IgM, it is not confirmatory that the person is suffering from the mumps virus. That is why we say that serological test is only a supportive test and not confirmatory test. Lastly, we have the viral isolation test. So this is the gold standard for laboratory confirmation. Here we are detecting the live mumps virus. The virus again can be isolated from either saliva, urine or CSF samples. We see that it is actually pretty useful in early detection before the antibody response has taken place in a person's body. Now here what we do is we use cell lines. These cell lines can either be continuous cell lines like Theo or HeLa, or we can also use the primary monkey kidney cells. So here, how are we confirming that the particular sample has live mumps virus? Is the cytopathic effect, which shows the syncytium formation. So once this syncytium formation occurs, we say that yes, this particular sample consists of the viral virus structure. To summarize it all, we see that there are three main methods. The one we are using most commonly in the clinical method is the RT-PCR one, and the one which is more commonly used for sample collection is the buccal or the oral swab. Thank you so much. Now I would like to call Aviral Bhati from the Department of Physiology to guide for the rest of the presentation. Thank you.
Good morning, faculty members, and my dear friends. Today I, Aviral Bhati, from batch 2021, stand before you stand before you to present the examination and differential diagnosis of parotid swelling from the Department of EM. After the discussion of anatomy, physiology, pathology, and microbiology of parotid, we move towards the examination and differential diagnosis of parotid. The presentation is prepared by my teammates Subodhika Burman, Jay Madnawat, Harsh Indra, and Shankar Singh under the guidance of Dr. Tatmuja Sir, Professor in Head, Department of PNT, and as a moderator of Priyanshi Gupta Ma'am, Assistant Professor in Department of PNT. After taking proper consent and his first proceed with the general medical examination followed by the local examination. Local examination consists of inspection, palpation, and auscultation. Now, what are the possible findings on inspection? First, we see whether the swelling is present unilaterally or bilaterally. A unilateral swelling may be indicative of a tumor, such as most commonly being pleomorphic adenoma and parotid cyst, and a bilateral swelling may be indicative of an infective etiology such as parotitis or mumps, and certain tumors such as Wattson's tumor. Size. The swelling should be within the parotid area as described earlier. Next step, size and shape. Large non-related, non-nodal and bossulated tumors are mostly seen in mixed parotid tumors such as pleomorphic adenomas. And irregular surface is usually observed in case of parotid malignancy, and smooth surface is observed in inflammatory etiology, as you can see in these pictures. Moving towards scar, sinuses, and dilated veins. Here we can appreciate the picture of a post-surgical scar, sinus, opening of a sinus, and dilatation of veins around the parotid gland. Skin over swelling. The skin over swelling may show erythema as seen in infective acute infectious etiology such as abscess and parotitis. Now we confirm our inspectory findings by palpation. Temperature and tenderness. In case of acute parotitis and abscess, a local rise in temperature and tenderness will be present. Surface. Smooth surface will be found in infective etiology and as like mumps. Size, shape, and edge will define the extent of disease. Consistency can be categorized into three subcategories: firm as in pleomorphic adenoma, hard as in malignant tumor, and soft or cystic as in Wattson's tumor and parotid cyst. Fixity. The fixity of swelling is determined by whether the swelling is fixed to the underlying structures such as muscle or overlying structures such as skin and soft tissue. Test is positive when the swelling has restricted movement or skin over the overlying swelling is not pinchable, and negative when the swelling is moved freely. Fixity is negative in case of mumps. Fluctuation test. We perform fluctuation test by placing two fingers of one hand a few centimeters apart on opposite sides of the swelling. We apply pressure by pressing down firmly with a finger on and palpate on the other finger. Positive test indicates the swelling contains fluid as in a cyst or abscess, and negative test contains swelling is likely solid or semi-solid and doesn't check fluid. Examination of oropharynx. First, we examine the parotid duct opening. There is a duct in parotid gland known as Tension's duct, which opens to near the opposite to the second molar, and obstruction in this duct is mostly due to stone or parotid capillaries. Next, we will do the bimanual palpation. We place one finger in the mouth, pressing the cheek laterally near the anterior torsicular pillar, and simultaneously place the other hand externally behind the angle of mandible to feel for deep masses. Auscultation. The humming sound on auscultation signifies vascular swelling in the gland. Lymph node examination. The preauricular, parotid, and submandibular group of lymph nodes get involved in parotid pathology and are examined as per lymph node examination. Facial nerve examination. Facial nerve terminates into 5 branches. We have to see for the absence of wrinkles on the same side, on raising eyebrows on same side, incomplete closure of eyelids on maximum effort on same side, leakage of air while puffing cheeks or inability to whistle on any deviation of angle of mouth to opposite side on smiling, and if the platypha on same side does not get prominent on clenching teeth. We can also observe these features in the patient who came to our OPD. Now, we'll head towards the differential diagnosis of parotid region swellings. The parotid region swellings can be classified into two parts: parotid gland swellings and swellings that may be parotid gland. For example, lymphadenitis, myxoma, infratic nephroid fossa tumor, fibroma, lipoma, mandibular tumors, neuroma, and parapharyngeal tumors. Parotid gland swellings can be further subclassified on the basis of facial nerve involvement. If present, the swelling is most likely malignant, and if absent, the swelling is most likely benign, which can be further subclassified into diffuse swelling and lump. The parotid swellings can be further subclassified into acute and chronic swellings. If the swelling is present for less than 6 weeks, it is an acute phase, or if present for more than 6 weeks, it is a chronic phase. Acute and chronic each can be subdivided into unilateral and bilateral swellings. Examples of acute unilateral swellings are parotid tabulus, suppurative parotitis, and parotid abscess. Examples of acute bilateral swellings are viral parotitis or mumps, preauricular lymphadenitis, and lymphadenitis of parotid nose. Examples of chronic unilateral swellings are plume of carcinoma, vascular or lymphatic swellings, Watching's tumor, and mucoepidermoid tumor. And examples of chronic bilateral swellings are sarcoidosis, Watching's tumor, and Jorgen's. In order to summarize the examination findings of mumps, it appears as bilateral parotid swelling with redness towards the swelling and the smooth surface associated with fever and no dilated veins and no lymph node swellings. Other salivary glands such as submandibular and sublingual may also get involved. Now, with this, I would like to conclude and call upon Nakshtra Jain from Department of Community Medicine to take this presentation forward.
The algorithm. Previous, yes. Facial nerve involvement. If it is involved, it would usually indicate malignancy. But it is not that if facial nerve is not involved, it cannot be malignant. In the initial stages, even a malignant tumor facial nerve may not be involved. On the other hand, as many of you have already mentioned, there may be temporary, transient, reversible involvement of facial nerve even in an inflammatory condition like mumps. So both the things are possible. It is not that if facial nerve is not involved, it is always benign.
I would like to add over here that recently we came across a case of a chronic parotid swelling which turned out to be tubercular, and the patient is presently on ATT, anti-tubercular therapy. So that too should have been in the next slide. You should have included under chronic one of the differential diagnoses of TB parotid, though it is very rare.
Good morning to one and all present here, respected dignitaries, all the faculty members and my dear colleagues. Myself, Nakshtra Jain from Batch 2024, going to present on the topic Epidemiology and Preventive Measure of Mumps. This presentation is made by Sumit Tawar, Niharika Bell, Nikhil Bansal and Tarushi Sharma under the guidance of Dr. Rajat Vora sir, Professor and Head Department of Community Medicine, and under the moderatorship of Dr. Shweta Mangal Ma'am, Professor, and Dr. Tushar Kalra sir, Senior Resident, Department of Community Medicine. At the end of this presentation, you will get to know about the epidemiology and prevention and control measure of mumps. As earlier mentioned by my colleagues, mumps is an acute contagious viral illness which spread through respiratory tracts. Name came from the British word mumps, which means grimace or grin, as because of the appearance of the patient, result of parotitis seems to be in grin. From 1999 to 2019, on average about 5 lakh cases were reported annually to WHO. But in last 5 years, on average about 3 lakh mumps cases reported to WHO annually. Globally, mumps incidence challenging to estimate as it is not a notifiable disease in many countries. Here you can also see in the graph picture that from 1999 to 2024, there were rapid increase in mumps cases, but to 2018, there were more number of cases in Western Pacific countries, but from 2018 to 2024, the number of cases in Africa has abruptly increased than the Western Pacific countries. In India, till 1999 to 2013, there were no national data, only localized studies exist. From 2014 to 2020, 150 to 500 IDSP outbreaks only reported. But from 2023, there was sharp rise in cases of mumps in various states like in Tamil Nadu, in Kerala, Maharashtra, and in recent years there were outbreaks in Rajasthan and Uttar Pradesh also. Now let's begin with epidemiology. Mumps spread through paramyxovirus, which is one antigenic type RNA type virus, which get rapidly inactivated by chemical agents, heat, ultraviolet lights. The second component of epidemiology is host. In pre-vaccine era, children aged from 5 to 7 years get usually affected. Now 5 to 15 years of age. Its epidemic period is every 4 to 5 years. Incidence is equal in both the genders. Complication of otitis in male is much more common than ophoritis in female, and its one attack gives lifelong immunity. Its reservoir is human asymptomatic infection may transmit. Respiratory drop nuclei transmit these diseases. It gets peak in late winters and spring. 3 days before to 4 days after the onset of active disease, this disease attains its communicability, and 14 to 18 days is its incubation period. For prevention and control measures, we have IDSP, that is basically Integrated Disease Surveillance Program, which aims to strengthen and maintain decentralized laboratory based on disease surveillance systemic for epidemic prone area to monitor disease trends, to detect and respond to outbreak promptly through a trained rapid response team. There are various other methods for controlling our sources or reservoir. We can try like long and variable incubation period. This disease is infectious even before it is symptomatic, and hence it becomes difficult to detect its cases. For interrupting its transmission, patients should stay away from other for at least 5 days after the onset of symptoms, that is basically isolation. Cover mouth and nose during coughing and sneezing with tissues. Practice good hand washing practice, and drinking and eating utensils should not be shared. Frequent touch surface, toys and doorknobs should be sanitized regularly. And from protection of a susceptible host, there were not a significant enough public health problem to warrant routine immunization, despite being a widely prevalent disease in the country. And at present, national immunization schedule does not include mumps, as it is considered as an optional vaccine. And MMR vaccines, measles, mumps and rubella vaccines. Usually mumps vaccine administered with measles and rubella, or with rubella also. It is a live attenuated viral vaccine. Its most common strain is German Lens strain. It shows 96% efficacy for measles, 93% for mumps, and 98% for rubella. It is administered subcutaneously with the dose of 0.5 ml. Its first dose is given at the age of 12 to 18 months of age, and its second dose should be given between 4 to 6 years of age. Precaution should be taken care of. Delay in vaccination if moderate or severe acute illness is noticed. Avoid in individuals with recent blood transfusion and immunoglobulin therapy. It should be stored at 2 to 8 degrees Celsius and need to be protected from light. Its common side effects are mild fever, rash, swelling at the injection site, and temporary joint pain. Febrile seizures, allergic reaction, and thrombocytopenia are its serious but rare side effects. And immunoglobulin ineffective for post-exposure prophylaxis, does not prevent disease or reduce complication. And transplacental maternal antibody appears to protect infant for the first year of life. So that's why first dose of MMR vaccine should be given at 12 to 18 months, because before first year, transplacental maternal antibody protect the child from this virus. Thank you. Now I would like to call Rishab Diwach from the pediatrics department.
Sir, it is not a notifiable disease in all countries. Do you know whether it is notifiable in India or not?
Well, not prevalence, but now IDSP has more improved. So
What is a notifiable disease?
that consideration of this disease as a main disease.
Yes, sir.
So it is not a notifiable disease at present. It is not a notifiable disease, and under IDSP it comes under other diseases. So that is one of the reasons that we are not able to collect the data exactly, as it is not a notifiable one. But due to resurgence in the last few years from 2023.
Disease is a disease which if any healthcare professional sees a patient, it is mandatory that you report it to inform the concerned authorities that
I have seen such a case. Recently, do you know any disease which has become notifiable in the last few years, which earlier was not notifiable? Any student? No? No student knows what disease which was earlier not notifiable. I don't know how many years, but recently has become notifiable. I hope I am correct. Tuberculosis. Everybody should know, because tomorrow you will become a practicing doctor. If you see a patient with tuberculosis and you don't report it, it may attract action. Because notifiable disease, that means that it is mandatory for a doctor to report it to the concerned. You should know whom to report and you should report it. About the vaccine, I was talking to Dr. Jaiswal also. I remember that our children received MMR because I thought it was part of the universal immunization program. It was not.
No, sir. So it is yet to be included, sir. It has never been a part of the national immunization schedule. Currently, they are using MR vaccine, measles and rubella vaccine, which is given at 9 months and 15 months. The IAP, the Indian Academy of Pediatrics, recommends the first dose of MMR at 9 months, the second dose at 15 to 18 months, and the third dose to prevent infection because of waning immunity in the adolescent and adults at 4 to 6 years. So the third dose is given in that.
Was it part of the optional vaccine that you could take, provided the pediatrician advised you?
Actually, the government looks from a public health point of view, and that is why, and they say that it adds to the cost of the vaccine as far as the bureaucracy is concerned. But presently, the Indian Academy of Pediatrics, it recommends from an individual health perspective, it recommends use of MMR in form of 3 doses.
Good morning to all the respected dignitaries. I am Rishab Diwach of Batch 2021 is here to present clinical features, management principles and complications of mumps. This presentation is prepared by Bhavya Solanki, Pawan Patel, Ayush Goel, Arnav Sen, under the guidance of Dr. Rupesh Masan sir, Professor and Head, Department of Pediatrics, and moderator Dr. Nikita Pal ma'am, Assistant Professor, Department of Pediatrics. Now, by the end of this session, we all get to know about the clinical features, complications, management, and a quick review of literature of mumps in India. Now, starting with the clinical features, 30 to 40% cases are subclinical. Prodromal phase, which is seen rare in children, lasts up to 1 to 2 days, which comprises of clinical features like fever, malaise, muscular pain, especially in neck, sometimes headache and vomiting. Salivary gland involvement is usually characterized by swelling in one or both parotid glands. In the picture, we can see unilateral parotitis. Parotitis, 70% cases are bilateral, which starts as unilateral and characterized by earache, jaw tenderness while chewing, dryness of mouth, and swelling of angle of jaw. As the swelling progresses, angle of jaw is obscured and earlobe is lifted upward and outward. In the picture, we can clearly see that the swelling at angle of jaw and the earlobe is lifted upward and outward. The parotid swelling proceeds rapidly, reaching maximum within few hours and usually peaks at 1 to 3 days. And it subsides gradually by 3 to 7 days and can last up to 2 weeks. Ingestion of sour and acidic foods or liquids may enhance pain in parotid area. Edema of homolateral pharynx and soft palate displaces tonsils medially. Edema over manubrium and upper chest wall may occur because of lymphatic obstruction. Mandibular gland swelling, submandibular gland swelling may also occur, and it can usually accompany or follow that of parotid glands. In the picture, we can clearly see the submandibular glands are swollen. In 10 to 15% patients, only submandibular glands may be swollen. Less commonly, sublingual glands are infected, but when infected, they are bilateral and characterized by swelling in submental region and floor of the mouth. Fever resolves in 3 to 5 days, and more biliform rash is a rare clinical feature that can also be seen. Immunized individuals have less severe symptoms, and parotitis may be absent in them. Now, coming to WHO case definitions, clinical mumps, acute onset of unilateral or bilateral tender, self-limited swelling of parotid or other salivary gland lasting 2 or more days and without other apparent cause. Laboratory confirmed mumps, a patient with clinical mumps and laboratory confirmation by positive mumps IgM antibody or seroconversion with 4-fold greater rise in mumps IgG titer or isolation of mumps virus from saliva, urine or CSF. Epidemiologically confirmed mumps, a patient with clinical mumps who is epidemiologically linked to laboratory confirmed mumps case. Now coming to the complications, the most common complications are aseptic meningitis with or without encephalitis, orchitis and oophorytis and pancreatitis. Uncommon complications are conjunctivitis and optic neuritis, mastitis, pneumonia, myocarditis, nephritis, arthritis and thrombocytopenia. Some rare complications are thyroiditis and sensory neural hearing loss. CNS involvement can be seen in 10 to 30% cases, in which the most frequent complication is meningoencephalitis. It may occur before, along with, or following parotitis. Its incidence is 250 cases per 1 lakh cases, and the 10% of cases are seen among people with the age group of more than 20 years of age. Clinical findings vary with age. Older children, adolescents, and adults are meningeal sign positive. Meningoencephalitis can occur with or without parotitis. Less common CNS complications are transverse myelitis, acute disseminated encephalomyelitis, aqueductal stenosis, hydrocephalus, and facial palsy. Coming to the second most common complication, orchitis and epididymitis. 30 to 40% of cases are seen among adolescents and adults. Among them, approximately 70% cases are unilateral. Onset is abrupt with high-grade fever, chills, lower abdominal pain, swelling of testes which can be painful or tender. Atrophy of testes may occur in 30 to 40% of cases. Infertility is rare, is even with bilateral orchitis. In the picture we can see the inflammation of epididymis and testes. Oophorytis. Although it is less common and less severe than orchitis in males, it is common in post-pubertal females that are adolescent girls and adult women after menarche may cause severe pain and tenderness. It can be clinically misdiagnosed as appendicitis when located on the right side. No evidence of infertility seen in oophorytis. Pancreatitis. Mild or subclinical pancreatitis is common, but severe form is rare. This may occur with or without parotitis and may be misdiagnosed as gastroenteritis. Clinical features comprises of fever with chills, epigastric pain and tenderness, vomiting. Elevated serum amylase level is characteristically present with or without clinical manifestations of mumps. In the CT image, we can clearly see pancreatic swelling and peripancreatic scarring. Arthritis. Migratory polyarthralgia and even arthritis are occasionally seen in adults, rarely in children. Occurs within 3 weeks of onset of parotid swelling. Symptoms last from a few days to 3 months. Most commonly involved joints are knees, ankle, shoulder and wrist joints. Arthritis is a mild complication and it is a self-limited complication. Deafness. It can be unilateral but rarely bilateral. Sensory neural hearing loss may be transient or permanent. Ocular complications comprise of dacroadenitis, which are painful swelling of lacrimal gland, and it is usually bilateral. Optic neuritis may occur Symptoms vary from loss of vision to mild hearing, and recovery occurs in 10 to 20 days. Myocarditis. Serious cardiac manifestations are rarely seen, while mild myocarditis is common then is recognized. ECG findings seen only in 13% adults in which ST segment depression can be seen. It presents as precordial pain, bradycardia, and fatigue. Now, coming to the management principles, no specific antiviral therapy is required. Management is mainly supportive and symptomatic. Isolation up to 5 days of onset of parotid swelling prevents spread via respiratory droplets. Symptomatic treatment comprises of rest, especially during the febrile phase, and maintain adequate hydration. Antipyretics and analgesics like paracetamol 10 to 15 mg per kg per dose repeated every 4 to 6 hours, and ibuprofen 5 to 10 mg per kg per dose repeated 6 to 8 hours. Warm saline mouthwashes can help. Soft diet is required and avoid sour foods as it can increase salivation and pain. Management of complications. Aseptic meningitis. Hospitalization and monitoring is enough. And to reduce cerebral edema, mannitol can be given. Orchitis. Bed rest, scrotal support and elevation, analgesic and NSAIDs. For oophorytis, analgesics and supportive care is enough. Pancreatitis, nil per oral initially, IV fluids and analgesics. Now, as my colleague Nakshtra Jain has covered the epidemiology part.
Is there any role of steroids to reduce the inflammatory edema, especially when pain is so much, or in neuritis or other organ inflammation?
Sir, as I said that there is no role of any other drug, while symptomatic treatment can be preferred by doctors.
There is no role of steroids. So there is no role of steroids, and moreover, there is always a risk of dissemination because complications are quite frequent in children, especially in post-pubertal children.
Mr. Bishop, you have mentioned there that the mumps orchitis infertility is very low. It is more about 50% infertility is due to the mumps orchitis. It is not rare.
Let me clear the...
Sir, I have said in the reference of the testis swelling. In oophorytis,
As far as the orchitis part is concerned, it was considered earlier that infertility is associated with mumps orchitis, but now this is more of a myth rather than a reality.
In experience of myself for the last 40 years, I can say with confidence that infertility in female, if you have it is mandatory to examine the testicles, and it is quite prevalent. Almost 10 to 15% of the infertile patients, male partner, if you do the palpation of the testes, you find the testes is too smaller in volume. You take the history of mumps in the childhood, you will come across, and mumps is not that uncommon. It is frequent, and you must, as a part of examination, must see the male partner for the evidence of the orchitis, past orchitis. So what you have said, I do not agree with that.
as my colleague Nakshtra Jain has taught about the epidemiology part, I want to just add on a quick review of literature of mumps in India. A study was done by Vasishtha VM et al. And published in 2015 showed that IDSP of Government of India has investigated 72 outbreaks with 1564 cases in 14 states during 2009 to 2014 and found that mumps meningoencephalitis was responsible for 2.3% to 14.6% of all cases of acute encephalitis syndrome. This calls for inclusion of mumps vaccine in National Immunization Program way back in 2015 by Indian Academy of Pediatrics. Another study done by Chandrakant S. Moge et al. In 2016 of mumps outbreak in Jaisalmer, which showed 84% of cases were school-going children and none of them were vaccinated against mumps. Another recent study done on mumps epidemic in Navi Mumbai in 2023-24 showed that out of 217 documented cases, only 20 cases have received MMR vaccine, while 197 cases were not vaccinated. As per the latest IAP immunization guidelines, mumps vaccine is to be given in 3 doses, scheduled first dose at 9 months, second dose at 15 to 18 months, and third booster dose at 4 to 5 years to prevent mumps outbreak in older children and adolescents. Efficacy of 2 doses is 86% to 90%. Now at last I want to conclude by recalling the typical manifestation of mumps, fever, malaise, painful parotid swelling, complications like meningoencephalitis, orchitis and pancreatitis may be involved even without parotitis. Complications are most common in post-pubertal age. Management is mainly supportive, no role of antiviral or antibiotics. Vaccination is paramount and timely immunization prevents disease and complications. So at last, I want to use this platform to appeal to Government of India to include mumps vaccine in national immunization schedule. Thank you very much.